Dr. Williams serves as the State Public Health Veterinarian for the Division of Public Health, where he's worked since 2004. In his capacity, is primarily responsible for zoonotic disease prevention and control with an emphasis on rabies and vector-borne diseases. He serves as a planning member for the annual One Health Symposium that's hosted by the NCDA and CS as well as NCDPHA, and serves as the co-chair for, and I don't know this acronym, NASPHV, Public Health Veterinarians, National Association of Public Health Veterinarians, Standard Precautions Compendium. So I'll let Dr. Williams go ahead and start with his presentation.
Whoop, that's not it. Sorry, Bruce. That's it. Thanks for inviting me, everybody. I work at the Division of Public Health and with a lot of people do surveillance for tick-borne diseases. And just as a brief introduction, we at the State Health Department do surveillance for approximately 77 odd conditions, which include mosquito and tick-borne conditions, but also all of the STIs, the foodborne illnesses, zoonotic diseases, viral hepatitis. So the state, like all of the states, does surveillance for a lot of conditions, and many of those include the vector-borne conditions. So what I'm going to focus on here today is just a brief overview of what we consider to be the big three, which is spotted fever rickettsia, ehrlichiosis, and Lyme disease. Certainly there are other tick-borne conditions that would be reportable, that may occur, but they occur in relatively low numbers, and we're just going to, in the interest of time, not discuss those, but I'd be happy to answer any questions if you have any later on. But these are some of the ones that seem to get a lot of attention. And again, the top three here are what we call the tick-borne rickettsial diseases, and they share some characteristics. Spotted fever group rickettsiosis, which was formerly called Rocky Mountain spotted fever, and you'll hear a lot of use of either of those terms. They're not necessarily synonymous, but they do get used interchangeably. And then ehrlichiosis and anaplasmosis, they're lumped together because they have a similar clinical presentation. Of course, they're treated the same way with doxycycline, and they can be serious illnesses that can be fatal. The bacterial disease of primary interest, of course, is Lyme disease. And then we have powassan, which would be reportable. It's actually an arbovirus. It's not a bacteria or a rickettsia, but it is transmitted by ticks. It is traditionally associated with the upper Midwest and New England, but there have been cases transmitted in Virginia, so it is something of interest, but we've not ever identified transmission here in North Carolina. But again, what I'm going to talk about are the three here that are kind of in the pink or the salmon color. Yes, sir. Okay, can everybody hear me okay? Oh, okay. Is that better? All right. Sure. How is it for you guys? I thought it was too loud, but it's right because I'm in front of the speaker. This must be why Pete Townsend went deaf. But what I'm going to do is just kind of jump into how we do surveillance for these conditions. So everything that's under surveillance has a case definition for surveillance that is essentially written by the Council of State and Territorial Epidemiologists and vetted and approved by the Centers for Disease Control. And this is a kind of simplified version. But what we need for to count something as a case of spotted fever group rickettsia, which is essentially a genus Rickettsia, species fill in the blank. It could be Rickettsia rickettsii, Rickettsia parkeri, Rickettsia amblyomai, and I'll get into a little bit of that in just a few minutes. But to count something as a case, you need a combination of clinical criteria and laboratory evidence of infection. So for a lot of our things that are under surveillance, especially the foodborne things, if you have a positive culture for salmonella, that's a case. All you need is the lab evidence. You have positive culture for Vibrio parahemolyticus or vulnificus, that's a case. We don't need a clinical illness to go with it. But for the vector-borne diseases, you need a combination of clinical and laboratory evidence. And if you have only one, it's not going to be a case. And one of the things I want to highlight right away is that creates this kind of dichotomy between a clinical definition and clinical management of a patient and a surveillance case definition. So a physician may well tell a patient, we believe you have Rocky Mountain spotted fever or Lyme disease, and that's fine. At the state, we may or may not count that as a case, because if one of these elements is not present, then it doesn't meet the case definition criteria. But you can see here that for spotted fever group rickettsia, you have to have a fever at a minimum, and then one or more of the following: rash, eschar, headache, myalgia, anemia, etc. So we're looking for that clinical evidence right away that would be supportive of an illness due to infection with rickettsia species. And then you need the laboratory evidence of infection. And what we're generally looking for with the spotted fever group rickettsia is a serologic test result. Oftentimes we only get one, but if it's at least one IFA that the laboratory performing the test says is positive, that's enough for a probable case. If we get that fourfold rise in titer, which is great, that's enough for a confirmed case. In North Carolina and nationally, we rarely get that second serum sample because people feel better, they don't want to come back to the doctor may not want to draw the blood sample. There's no clinical need for it. There is a surveillance need, but that's kind of secondary to clinical management. And then for these conditions, you could also have DNA detection or demonstration by immunohistochemistry. But we rarely see those, but they are parts of the case definition. So with that in mind, these are the statewide case counts for what used to be called Rocky Mountain spotted fever up until 2009, and then in 2010 became spotted fever group rickettsia. And that was a case definition change from the CSTE in recognition of the fact that our serologic tests cannot discriminate between rickettsia parkeri, rickettsia, amblyomyi, and perhaps others. So what we're counting is not necessarily an infection with rickettsia rickettsii. That's what we always thought, but now we know there's likely other rickettsias floating around out there. And in fact, our prior state epidemiologist, Dr. Engel, did work with Dr. Apperson and Dr. Harrison in Chatham County looking at infections with what was likely to be rickettsia amblyomyi causing what we thought at the time was rickettsia rickettsii. But what you see here and what's notable nationwide is that the vast majority of our cases are probable because we never get that second serum sample. So that's just a fact. These diseases have a seasonal distribution. That should be no surprise. You see an uptick starting right now, but definitely in May. This is for 2016, and those are confirmed and probable cases together. But you'll see a similar distribution with Ehrlichia and Lyme disease. These are summertime illnesses. This is average annual incidence for confirmed and probable cases over the 5-year period shown, and this is again based on cases that are reported to us. And we know well that there is underreporting. That's a common feature for everything. There's underreporting for salmonella, for gonorrhea, and for Rocky Mountain spotted fever. And for all of the 77 conditions under surveillance, there's probably underreporting. The extent to which it occurs is difficult to say, but in any event, you can see that we regard the distribution of spotted fever rickettsia as essentially statewide, although clearly there's more in the northern and central parts of the state. And this is a little bit dated, but actually is the most current map from the Centers for Disease Control. And what's interesting here is that North Carolina usually but not always leads the nation in the incidence rate of spotted fever group rickettsia. And these conditions kind of occur in a band from east to west, going from North Carolina over to Oklahoma. So while this condition was initially described and characterized in the Rocky Mountains, the true burden of disease really is in the southeast and south central part of the United States. And this is just a little detail, and some of you I know are very familiar with this for people who come to our vector-borne working group, but when you look at the number of events that are created for investigation by state and local health department personnel, it's really quite significant. So you can see that in 2016 we investigated over 2,100 possible cases of spotted fever group rickettsiosis, but only 477 of those met the case definition criteria. Generally what happens there, because we have electronic laboratory reporting, physicians will order tests for Rocky Mountain spotted fever or Ehrlichia or Lyme disease. It's positive, comes into our surveillance system automatically, but just because it's a positive lab doesn't mean it's a case. We have to look for that clinically compatible illness, and in most cases it's not present. So what this shows is a couple of things, is that there's a lot of work that's done by your state and local health department to investigate these tick-borne cases that most of them don't turn out to be actual cases. And what you also see is that the effect of electronic laboratory reporting on surveillance at the state level, since we've initiated that, it has really enhanced our capture rate for potential cases of about everything. So a lot of the hospitals in the state automatically feed positive results to us, as well as some of the commercial labs like LabCorp. That's the biggest one. So we get most of our notification about possible cases through electronic lab reports. We don't get many cards from physicians anymore. We still get some, but not many. And this is just a summary of the case definition change in 2010, and actually some folks from North Carolina worked on elucidating that information. Joey Johnson at the state lab and Megan Vaughn, who was a graduate student with Steve Meshnek at UNC, looked at serum samples from North Carolina and demonstrated that there's cross-reactivity across Rickettsia, Parkeri, Amblyomyi. So it truly is, those serologic tests that were developed decades ago are not species specific, they're genus or group specific. And then these are some of the other conditions that we talked about, and what's, I think you're going to hear more about the actual ticks. Rickettsia rickettsii, with a causative agent of RMSF, is historically thought to be vectored by Dermacentor variabilis, which apparently is a very rare tick in this part of the country. The Tennessee and Virginia state health departments have done tick surveillance, and that tick is rarely found, and when it has been found, it's not infected with Rickettsia rickettsii. So what's causing their RMSF cases? Probably some of these things, because we know Amblyoma americanum, the Lone Star tick, they're a dime a dozen. You could probably find some out here right now if we walked out of the restaurant. And they're a very aggressive human-biting tick. Parkeri, and I'm sure Dr. Harrison will talk about this, is present in North Carolina. The unique thing about Amblyoma maculatum, which is a vector for Rickettsia parkeri, is it causes an eschar at the site of the tick bite, which Rickettsia rickettsii does not. So that's kind of a distinctive feature. If you're a clinician and you see that eschar at the site of a tick bite, feel free to give your local or state health department a call, because we'd be interested in possibly pursuing some extra diagnostics with that. But these are, excuse me, are probably the other conditions that are causing our high counts of what we would call RMSF. And then this is data from the Centers for Disease Control again. It shows that while the incidence rate has spiked in recent years, the case fatality rate has dropped. RMSF used to be thought of as primarily a pretty serious disease, oftentimes fatal, and it's really not anymore. So the big question is why? And it's either due to prompt and appropriate therapy from clinicians, which is certainly possible, or it could also be due to infection with less pathogenic Rickettsia species like Parkeri and Amblyomyi. This is one of the things we always emphasize with RMSF is that there is a classic clinical presentation, but don't wait to see all these symptoms before you initiate treatment. Treatment for Ehrlichia infections and rickettsial infections is paramount because these can be fatal diseases. If you see somebody with a rash like that, a petechial rash, that's something you want to try and avoid. Obviously don't wait until you might see a rash to initiate treatment, and certainly don't wait for confirmatory testing. If you have a clinical suspicion of RMSF or a rickettsial disease or an Ehrlichial disease, go ahead and initiate therapy with doxycycline. And this is a common feature with serology. You test early in the course of illness, but the body may not have mounted an immune response. You may get a falsely negative result if there's a true infection. Same thing can be said about Lyme disease, about Ehrlichia. So just be aware of that fact that if you test early in the course of illness and it's negative, doesn't necessarily mean that the condition isn't present. You might have tested too soon. So in that regard, you can always try and get a convalescent serum, which would help confirm the diagnosis for all three of them, in fact. But again, the key thing here is if you suspect it clinically, but the test might be negative, certainly don't wait on treatment. And then the CDC has been making a big push about doxycycline use in children. It is appropriate for RMSF or any rickettsial or Ehrlichial or anaplasma infection. Back when the tetracyclines were first introduced in the 40s, there was an association with dental staining, but it is much less of a problem with doxycycline, which is a newer antibiotic, and both the American Academy of Pediatrics and the CDC recommend that if you suspect RMSF or rickettsial infection, any age patient, doxycycline is the drug of choice. And you can get these, there's a lot of references. This is just one that is nice and a good summary that's available on the CDC website. So monocytic ehrlichiosis, very similar to what we just talked about with Rocky Mountain spotted fever. You can see the case definition requires combination of clinical criteria and lab evidence, and you can see the clinical criteria, it's the same as what it was for rickettsias. And the laboratory evidence is the same. It's the same type of serology. So you need both of those, though, for us at the State Health Department to officially classify a case as Ehrlichia. And you can see here the cases of Ehrlichia over the years, they're much fewer than what you would find with RMSF, but we have a much higher percentage of confirmed cases. So we do, for whatever reason, get a lot more clinicians on a percentage basis that order that convalescent serology for Ehrlichia. This is representative of what you'd see in the national A2. Most of the cases are still left as probable, but there is a higher percentage of confirmed cases. And there is a seasonal distribution, a little bit tighter distribution here than what you'd see with spotted fever group Rickettsia. But again, you can see the numbers are quite a bit smaller, only 61 cases in North Carolina last year. Distribution looks fairly similar to what we saw with RMSF, but again, we tend to think of this as a statewide condition, but clearly there's a predilection for the northern and the central part of the state. And again, we see that North Carolina is a state with a high incidence rate. There's many of the same states that had a high incidence rate for RMSF. What's unique here is that Wisconsin is also in that high incidence category. That's a state that historically has not had the primary vector. Now, the primary vector for monocytic ehrlichiosis is the Lone Star tick. And there's various animals that serve as the reservoir, and I'm sure you'll hear about that later. The white-tailed deer is a recognized one. ticks pick it up when they feed on the deer. But that tick's known distribution, to the best of my knowledge, doesn't extend as far north as Wisconsin. So I'm not sure how to explain that, but there is kind of a similar distribution between rickettsia and monocytic ehrlichiosis on a national basis. And again, you can see kind of the same thing here. The number of events that are created for investigation is much smaller for monocytic ehrlichiosis. Again, most of them are created by an automatic laboratory feed. There's been a rising percentage, from 20,000 or 2009, only 6% of our cases came in through electronic lab reporting, but now 85% last year. So ELR is a significant impact on our ability to do surveillance, and not only for vector-borne, but for food-borne and STIs and basically all categories of disease. Lyme disease. Now this one is probably the one that most people are interested in and we seem to get the most questions about. And I don't have a simple clinical presentation here. Note it says see next slide, and we'll get into that. But this is the same principle applies. You have to have laboratory evidence of infection and a clinically compatible illness for us at the state to classify it as a confirmed or probable case of Lyme disease. And that may differ from a clinical diagnosis and what a physician tells their patient. So the clinical criteria for Lyme disease. Erythema migrans is what is referred to as the early localized phase of disease. That is when you have a bite from an Ixodes scapularis tick, which, based on the Diener surveillance that was done about 10 years ago, the tick is present in North Carolina. It's not nearly as common as the Lone Star tick, but the vector is present in the state. If it bites and it transmits Borrelia burgdorferi, many patients, but not all, will develop this expanding reddening rash, which is called an erythema migrans rash. In the old days, that alone was enough to count as a confirmed case of Lyme disease. And that still is if you're in a high incidence state like, say, Wisconsin or Minnesota. The problem in the southern states is that EM rash is confounded by stari, which I'm sure many of you have heard of, which is an expanding reddening rash subsequent to a tick bite, commonly a Lone Star tick bite. So there's confounders in the south that aren't present in the northern states that make surveillance for Lyme disease a little bit more challenging here, even though the case counts are likely to be much higher in places like New York and Wisconsin. But then there are other clinical manifestations. There are what are called late or systemic manifestations involving the musculoskeletal system, the nervous system, or the cardiovascular system. And if any of these conditions are met and there's laboratory evidence of infection, then we could count that as a confirmed case of Lyme disease. The trick is you have to, when you get the positive lab, which is about how most of our events are identified, we have to go work backwards, talk with the clinician, talk with the local health department to find out what was the clinical presentation and did it match one of these criteria that would allow us to call it a confirmed case of Lyme disease. The laboratory testing is also a little bit more complex than what we're used to with Rocky Mountain spotted fever. There is two-tier testing, which has been the standard recommended by the CDC since the mid-90s. It has shortcomings, but it is currently essentially the only recognized way of diagnosing Lyme disease, at least for surveillance purposes. Is an initial ELISA that's positive or equivocal. Then you need a positive Western blot. And if your illness or the patient's illness has been 30 days or greater, there must be a positive IgG Western blot. IgM alone would not be sufficient. So a lot of times we'll get a positive ELISA with nothing else. That doesn't meet criteria. because it doesn't have the second stage, the Western blot. Or we might just get the Western blot without a preceding ELISA. That, again, does not meet criteria. Or we might get a patient who's been ill for 2 months and they're 2-tier positive but only IgM. That doesn't meet criteria, because if you're ill for longer than 30 days, you have to have IgG positive. Again, this doesn't mean the clinician can't tell the patient they don't have Lyme disease, but it does mean we're not going to count it as a case, because we have to meet these national surveillance criteria. So here is the cases of Lyme disease by year in North Carolina. You can see that for the past 10 years, our cases of confirmed Lyme disease have been remarkably stable. Where we do see the increase is in the probable case classification. Now, I listed all those clinical criteria earlier, and that's for a confirmed case. To be classified as a probable case, all you need is a physician to say, you've got Lyme disease. There can be no objective clinical manifestations. Somebody could come in, not feel well. If they're positive with that 2-tier testing and the physician says, I think you've got Lyme disease, that actually meets the criteria for probable. So it's pretty loose. But that's where we see the vast increase in the number of our cases of Lyme disease. Again, a seasonal distribution. Yes, sir.
Do you think that's a real increase in Lyme disease, or is it a case definition?
So that's a great question. Dr. Harrison was asking, is it a real increase? Is it an artifact of the case definition? One of the things that gets a lot of discussion is the clinical indications for testing. And there have been several articles, most recently one from last July, that address when should you test a patient for Lyme disease, and it's based on what they call the prior probability of disease. If it's high, you should test. If it's low, you shouldn't. As a general rule with, as epidemiology, you know that in an area where if there's a relative low incidence of disease, but you apply the test broadly, you're going to have a greater incidence of false positive results. Could that be happening here? It's definitely possible. Certainly there have been articles written that have suggested that. So I think I don't have a specific definitive answer, but I think it's definitely possible. And I think that's why when the CDC looks at whether or not a state is high incidence or low incidence, they only look at confirmed cases, because we have a greater degree of confidence in that confirmed case definition nationally than we do with the probable case definition. This is incidence for confirmed and probable cases. What would be good that I didn't include, but is the map that would just look at confirmed cases. And I think what is interesting about Lyme disease is to look at what's happened in Virginia over the past 15 years. In 2000, Virginia was a low incidence state for Lyme disease, saving for the national capital area. But in that time frame, you saw a tremendous uptick in cases that followed the foothills of the Virginia mountains. And if you look at a national map, and again, this one is a little bit dated, but you can draw a line and you see that there's a cluster that is essentially just north of Allegheny, Ashe, and Surry County. And it would lead you to think that this disease has been emerging in Virginia parallel to the foothills of the Appalachian Mountains, and that if it's going to really make an impact in North Carolina, it's going to be in the northwestern part of the state. Susan Little from Oklahoma State and David Gaines from the Virginia Department of Health have done studies just north of the state line in state parks in Virginia, maybe not just north, but 30 miles or so, pretty close. They're finding a lot of Ixodes scapularis ticks. 30% of them in some areas are found to be infected with Borrelia burgdorferi sensu stricto. So clearly this is a condition that is the vectors present in Virginia. The vectors are carrying the pathogen in high numbers in that part of Virginia. And those parts of Virginia are very close to the northwestern part of North Carolina. And so that is of keen interest to both us and the Centers for Disease Control to find out what might be happening in that part of the state. And that's, I think you might hear more about that as we go through the day, but that's something to keep an eye on, because Lyme disease, we know it can be acquired in this state. We know the vector's present throughout the state, yet the incidence rate is not what it is in Wisconsin or Connecticut. So we're not a high incidence state, but neither was Virginia at one time. So things can change. So that's something we want to keep our eye on. And then again, with Lyme disease, this one's a little bit different because we've always seemed to receive a lot of these by ELR, but just like the others, we get a lot of events created for investigation, 1,200 last year. But again, most of these don't meet the case definition criteria. So you get that positive lab, but that positive lab does not mean it's a case for surveillance purposes because it doesn't meet the case definition criteria. And then this is just a little bit of our surveillance algorithms. And I think, are these slides going to be made available to people? Yeah, so I won't spend too much time on this, but this is kind of what we've done is try to put down our thought process of how we get to, is a case confirmed, is it suspect, is it probable? But this is starting with an EM. This is starting with late manifestations. Of course, those are the objective clinical manifestations. And then this is, does the physician diagnose Lyme disease? Because they just do. But there's no objective clinical manifestations. And that's how this is the one, the algorithm that actually leads you to the vast majority of our Lyme disease cases. And that's it. I hope I'm on time. I don't know how you want to do questions.
Yes,
or...
we have just a couple of minutes for questions.
Okay. Yes, sir.
Do you think that, looking at these regressions of increasing possible diagnoses, that it can be related just to more people getting out into an area where there are ticks and they just knee-jerk and think that they've got this problem, and also that we have an increased population as well. So those two factors together can more increase in probable without confirming.
Yeah, and what I didn't show are incidence rates by year. Those are just raw numbers. So it's very possible that there could be an effective population there that we're not adjusting for. And it could be that there are people who just want to be tested. I don't know. We don't get into necessarily the why of a person was tested, just trying to ascertain were there any manifestations of illness now that they have been tested. But I think it's certainly possible. Yes, ma'am. I couldn't, can you repeat that? I couldn't hear.
Why is the incidence of alpha-gal
Oh. Yes,
not being tracked?
yeah, so the question was about alpha-gal, which is the allergy associated with I think it's a polysaccharide that's it occurs. Yeah, it's common to both tick saliva and red meat. So it's not infectious. It's not a condition under national surveillance. So it's not a condition under state surveillance. So it's not under surveillance in any state. Yeah.
You're saying it's not infectious.
Correct.
Well, I mean, it doesn't spread from one person to another, but neither does Lyme disease. So
True.
disease given to a person by a tick. So why is that not?
What?
Okay.
Yeah. It's not infectious in the sense that it's not a rickettsial bacterial or viral organism. It's an allergic reaction, so it's not under surveillance. Yes.
My understanding with the CDC definition for Lyme, confirmed Lyme was that you have to stay within the county for 30 days before. Is that true of the state definition?
Yeah, so the case definition changed this year, and they dropped the endemic county concept. But what we're looking at now is there exposure in a high incidence state, right?
What you showed there coming up and how so many tests came positive, but then you couldn't confirm them. Up until this year, they were restricted by the 30 days of the county.
Right, so this is, we could spend another hour talking about this endemic county issue, but yeah. So the endemic, there used to be, I think, about 6 endemic counties, which, to be classified as endemic, we had to have identified 2 confirmed cases by EM that were believed to have been acquired in the county over any time frame. So we had some counties that were endemic based on a case in 2010 and 2015 or something like that. So that has now been deleted because it was really difficult to manage, not only on a statewide level, but on a national level. So the CDC is looking at, do you have exposure in a high incidence state, and they will define what the high incidence states are.
But my question was, he's showing that you get a lot of positive labs, but they don't confirm. It's only
Right.
20-some%. If you're restricted by the 30-day thing, that's when a lot of
The 30-day thing, well, no, because if we have a positive lab, many times what we find is there's no objective clinical criteria at all. There was never any EM, there was never any musculoskeletal or cardiac or neurologic manifestation. So there's no clinical indication, which, again, when you look at this issue of prior probability of disease and why was the person tested in the first place, it does lead you to ask the question, well, should they have been tested at all if there's no prior probability of disease, or if it's low? If they didn't have exposure in a high incidence area, if they don't have any objective clinical manifestations, it's not for us to decide. That's a clinical issue, but it does affect surveillance.